This is ABSITE and board review for malignant pancreas tumors. Be sure to check out the talk on benign pancreas for anatomy, function, and pancreatitis issues. Let's start with discussing adenocarcinoma of the pancreas. Adenocarcinoma is usually from the duct cells and is called pancreatic ductal adenocarcinoma and abbreviated as PDAC. KRAS is the most common mutation in pancreatic ductal adenocarcinoma. 60 to 80% of tumors occur in the head and uncinate, with the other 20% or so being in the body and tail. The body and tail tumors tend to present later since they do not cause any symptoms or biliary obstruction. Classic findings of weight loss with painless jaundice signify cancer in the head of the pancreas. Remember the classic findings of acolic clay-colored stool, dark urine, pruritus from blockage of bile, and the large palpable non-tender gallbladder from backup of bile into it, called the Cavorsier's gallbladder. Drop metastases to the pouch of Douglas and the pelvis are called Bloomer's shelf, and carcinomatosis in the belly button is a Sister Mary Joseph nodule. Left supraclavicular lymph node is a Virchow's node. These are all findings of stage 4 disease, and they would not be a surgical candidate. Be sure to get a CT pancreas protocol, which means that you do thin cuts through the pancreas and a triple phase with good arterial and portal venous phases of the IV contrast. Tumor marker for pancreatic adenocarcinoma is CA19-9, although about 10% of cancers don't secrete this at all. Risk factors for pancreatic adenocarcinoma include smoking, chronic pancreatitis, and genetic mutations such as BRCA. You should divide pancreatic head cancer into really 3 categories: resectable, borderline resectable, also called locally advanced, and unresectable. 80% of pancreas cancers are unresectable at diagnosis. If a tumor invades the SMA, it completely occludes the portal vein, or has metastatic disease, then don't do a Whipple. It is unresectable. If a tumor invades just a portion of the SMV portal vein, or has multiple peripancreatic lymph nodes but no distant metastatic disease on imaging, then this is called locally advanced or borderline resectable. And consider neoadjuvant chemotherapy with or without radiation, although the data on this is still a little bit in evolution. About 80% of curative resected pancreatic cancer recurs within several years, so they all get adjuvant chemotherapy if possible, usually with gemcitabine-based therapy. So giving neoadjuvant therapy does make sense in locally advanced cases, so I doubt an examiner would give you too hard of a time for at least discussing it. Resection of the SMV and portal vein is done routinely when involved. This shows better outcomes than no surgery at all. The resected piece of the vein wall can be repaired with a patch or just a segmental resection and reanastomosis. Clearly resectable pancreatic head cancer has no invasion of the SMV or the portal vein. It is not near the SMA or the hepatic artery, and there is no metastatic disease. These traditionally go straight to surgery and then get adjuvant chemotherapy. EUS, or endoscopic ultrasound with a biopsy, is the best way of confirming cancer prior to surgery, or if surgery is not an option and you need tissue. EUS can actually use a larger needle to go directly into the head of the pancreas, giving the proper tissue for diagnosis. It is important to rule out autoimmune pancreatitis, which can look similar to cancer on imaging. Autoimmune pancreatitis is elevated serum IgG, diffusely dilated sausage-like pancreas, although focal areas can look like cancer. It is usually treated with steroids. ERCP with a stent is done only with the guidance of the pancreatic surgeon. A general protocol is that if the bilirubin is very high, say over 8, and the patient is malnourished, then preoperative plastic stent placement makes sense so bile can get into the intestine and help build nutrition prior to surgery. The downside is that once stenting is done, the infectious risks of surgery go up significantly. So if somebody is caught early with minimal elevation of bilirubin and good nutrition, stenting may not be needed. If the patient is going to be able to have surgery after a few weeks of nutritional improvement, a plastic biliary stent is okay. A metal wall stent to hold the bile duct open is generally preferred if the patient is not a candidate for surgery, or if they will be getting several months of neoadjuvant therapy prior to surgery. This is since the plastic stents tend to clog and they can cause cholangitis if left in too long in pancreatic cancer patients. Let's talk about surgery a little bit more in depth. A diagnostic laparoscopy can find carcinomatosis or small volume disease missed on the CT scan in about 15% of cases. I would definitely do a diagnostic laparoscopy prior to the full incision in locally advanced cancers. The Whipple surgery is done for cancer in the head of the pancreas, or distal common bile duct cholangiocarcinoma, or periampullary cancer, or a duodenal cancer in the C-loop of the duodenum. Know that the basic steps of a Whipple are that the distal bile duct, the gallbladder, the C-loop of the duodenum, the head of the pancreas, and the first portion of the jejunum are all removed. The pancreaticojejunostomy is performed typically first, followed by the hepaticojejunostomy and anastomosis, followed by some sort of gastrojejunostomy. Don't use permanent suture in the bile duct for risk of stone formation. The most common anastomosis to leak is the pancreatic anastomosis, and this is worse if the pancreas is soft and the duct is small. It is very common to have delayed gastric emptying post-Whipple, and some surgeons leave feeding tubes in the stomach and the jejunum to help with decompression and feeding. Bleeding post-Whipple is best treated with IR if possible, since the tissue is friable and there are a lot of tenuous anastomoses in the way of the bleeding. Usually the bleed will be from the stump of the GDA or the gastroduodenal artery on tests. Body and tail pancreatic ductal adenocarcinomas are treated with distal pancreatectomy, usually with splenectomy, in order to ensure that a good lymphadenectomy has been performed. Let's talk about cystic tumors of the pancreas. Cystic neoplasms of the pancreas are a common topic on tests now. Benign things that can look like cysts would be a serous cystic tumor, which are actually usually benign, a benign cyst, or even a pancreatic pseudocyst. If a cystic lesion is seen on imaging, be sure to order a high-quality, thin-cut pancreas protocol CT, and probably also an MRCP to see the pancreatic duct better. Any cystic lesion with symptoms, or if it's over 3 centimeters in size, or is causing dilated pancreatic duct, or has multiple septations, or has a nodule or thickening of the cyst wall, and has a solid mass maybe also associated with it. All of these need endoscopic ultrasound with biopsy then. Any cyst without these characteristics, you could just repeat the MRI annually for a few years to follow it. If you end up doing the EUS and you think it's benign, still follow with imaging, but you could resect if diagnosis can't be determined at this point, or if it's large or has symptoms. There are 3 cystic neoplasms with malignant potential to know about. Solid pseudopapillary neoplasm, or SPN, mucinous cystic neoplasm, or MCN, and intraductal papillary mucinous neoplasm, or IPMN. Solid pseudopapillary neoplasm, or SPNs, are rare. All you need to know that is if a young woman has a heterogeneous multicystic lesion that is usually in the tail of the pancreas, and a biopsy shows SPN, then you should resect due to risk of malignancy in the future. The key words for mucinous cystic neoplasm, or MCN, is that they usually occur in the body and tail. A biopsy of these will show ovarian-like stroma. All MCNs should be removed, usually with distal pancreatectomy. IPMN tends to be the most common thing asked on tests, so let's focus on that. As mentioned, dilated pancreatic duct can be a sign of a growth in the pancreatic duct, which is what the intraductal means in IPMN. IPMNs tend to occur more in the head and the unsnit process. Endoscopic ultrasound is how IPMN is really diagnosed. The fluid from the cyst is sent for a mucin stain and a CEA level. A CEA level over 192 nanograms per milliliter, a low amylase level, and positive mucin in the cyst is very concerning for an IPMN. The endoscopy may mention mucin also protruding from the ampulovator, which sometimes is called a fisheye look. The next decision, once you are suspicious of an IPMN, is to determine whether it is a main duct or a branch duct IPMN, or a mixture of the two. MRCP and EUS with ERCP should show the pattern of connection to the pancreatic duct. As a general rule, if a test tells you specifically that it is a main duct or a mixed IPMN, it should be resected. But definitely resect any IPMN if it dilates the pancreatic duct greater than 1 centimeter, since this is probably a main duct type. Branch duct IPMN, should be resected anytime it is over 3 centimeters in size. I would also resect any IPMN if it has mural nodules, an associated solid component, or is symptomatic, especially with biliary obstruction. IPMN itself is not really a cancer per se. The reason we remove it is because it leads to regular pancreatic adenocarcinoma, so the goal is to remove it before this happens. Let's move on and talk about pancreatic neuroendocrine tumors, or PNETs, as these are often a common topic on tests. The topic and the terms get confusing, so here is a general organization. Think of PNETs in 2 broad categories, functional and non-functional. The majority are actually non-functional. PNETs are also subclassified as low-grade, intermediate grade, or high-grade based on mitotic rate and the Ki-67 percentage. A low-grade, non-functional neuroendocrine tumor that is less than 2 centimeters in size are sometimes simply observed, but anything larger than this you should surgically remove. Resect all intermediate and high-grade non-functional PNETs also. All pancreatic neuroendocrine tumors have a propensity to metastasize to the liver. Debulking low-grade neuroendocrine tumor metastasis to the liver improves outcome, especially if they're hormonally functional. Talk a little bit about imaging. So imaging of pancreatic neuroendocrine tumors is a common question. In general, always start with a triple phase CT of the liver and pancreas for any suspected pancreatic tumor. Neuroendocrine tumors tend to be enhancing on arterial phase. Octreotide scans used to be a common answer for pancreatic neuroendocrine tumors. However, almost all neuroendocrine tumor imaging is now done with PET dotatate scans, which is a somatostatin receptor scintigraphy scan using a PET technology. This has largely replaced octreotide scans. So the other broad category of PNETs are hormonally functional tumors. These make hormones, and the most common ones you will see on tests produce the following hormones: insulin, glucagon, somatostatin, vasoactive intestinal peptide or VIP, gastrin, and serotonin. So let's go through these. Alpha cells in the islet of Langerhans make glucagon. A glucagonoma is very rare. It tends to be malignant. They can present with a dermatitis called necrolytic migratory erythema. This tends to occur on the perineum and the legs. It is commonly associated with DVTs, and it can cause diabetes from the excess of glucagon. So remember that as dermatitis, DVT, and diabetes, or the 3 Ds. Beta cells can make insulin, and a tumor of these cells is called an insulinoma. This presents with Whipple's triad, which is hypoglycemia, usually less than 50, symptoms of hypoglycemia, and resolution of symptoms with administration of glucose. C-peptide in the blood is present in a true insulinoma. It is not present if somebody is giving themselves insulin. Insulinomas are the most common functional pancreatic neuroendocrine tumor. They are typically benign. They can occur anywhere in the pancreas. There used to be a question that said octreotide scans will not show these, although sometimes PET dotatate scans will. Next, delta cells can make somatostatin. A somatostatinoma, however, is extremely rare. It can present with gallstones and diabetes and diarrhea because the somatostatin shuts down gallbladder and pancreas function. The next few neuroendocrine tumors of the pancreas are actually not from native endocrine cells that are normally found in the pancreas. The next extremely rare tumor comes from the VIP producing cells and is called a VIPoma. VIP stands for vasoactive intestinal peptide. This presents with WDHA, which stands for watery diarrhea, hypokalemia, achlorhydria syndrome. This is also known as pancreatic cholera because of the severe diarrhea, and it's also known by the eponym Werner-Morrison syndrome. Okay, let's unpack the next 2 a little bit more thoroughly since they are tested more commonly in depth. The first one to look at is gastronoma. Normally gastrin is from the stomach, antral G cells, so to have it in the pancreas is a little bit ectopic. Note that gastronomas are also known as Zollinger-Ellison syndrome. Most gastronomas can be found in the gastronoma triangle, which is formed by marking the junction of the cystic duct and the common bile duct, the head and the neck of the pancreas junction, and the second and third portion of the duodenum junction. Gastronomas have a higher risk of malignancy than Insulinoma, but not as high as Glucagonoma. The gastrin increases acid production from parietal cells in the stomach and causes severe ulcers of the stomach, and even through the duodenum and jejunum. It inactivates the pancreatic enzymes, which leads to diarrhea. Gastronomas are commonly associated with the MEN1 syndrome. If the patient has parathyroid disease, be sure to treat the parathyroid disease first, as the hypercalcemia can drive the gastronoma to be hyperfunctional. If the patient has MEN1, only do surgery for the gastronoma if the lesion is visible on imaging, since they tend to be multifocal. For a sporadic gastronoma not associated with MEN, it is okay to explore without a visible lesion on imaging. Exploration for a sporadic gastronoma without preoperative localization should include the following: intraoperative ultrasound, and perhaps a duodenotomy with palpation for submucosal gastronoma in the duodenal wall. Okay, next we'll talk about a low-grade neuroendocrine tumor, whether functional or non-functional, was historically called a carcinoid tumor, although some purists say this is old nomenclature and should not be used. But regardless, the term carcinoid is still commonly found on tests, so consider it an interchangeable term for low-grade serotonin-producing neuroendocrine tumors. Most serotonin-producing carcinoids are from midgut tumors in the bowel, so it is actually relatively rare to get it from a pancreatic neuroendocrine tumor. However, if a pancreatic neuroendocrine tumor is making serotonin, urinary 5-HIAA, which is a breakdown of serotonin, and serum chromogranin A are the lab tests for this. If a serotonin-producing carcinoid, it could possibly cause carcinoid syndrome, but this usually occurs only after metastasis to the liver, when the serotonin can then bypass hepatic metabolism and cause the actual systemic symptoms of the carcinoid syndrome. Carcinoid syndrome is characterized by flushing, diarrhea, tachycardia, valvular disease of the right heart from long-standing serotonin excess. And since tryptophan is diverted to make serotonin, niacin levels go down, causing pellagra, which can cause dermatitis, dementia, and diarrhea. Treatment is resection of the primary tumor and octreotide treatment for carcinoid syndrome. I hope that helps. Don't forget to check out the other videos on benign pancreatitis problems. Good luck.